Yeah, good evening, and thanks to the Kerala State Ophthalmic Society. We have Dr. Rajiv here, and we are having this session, the FP10 Apots session, my most challenging case and how I managed it. So myself and Dr. Gangadhar Sundar are moderating, and we have Dr. Caroline Chi and Dr. Rupesh Agarwal to moderate. Over to you, Dr. Rupesh.
Maybe I'll just make just a few comments.
Sorry, Ganga. And we have Dr. Gangadhar Sundar as the scientific chair of Apots, who's the vibrant man keeping all of us active even on a Sunday and keeping Stephanie at 9 o'clock in the night.
Thanks, Dr. Natarajan. Actually, I'd like to thank Dr. Rajiv Sukumaran and the organizing team of Kerala State Ophthalmic Society for giving us an opportunity. We strongly believe in multidisciplinary, multinational approaches, and we have put together a program which is basically a case-based learning, because it's the individual cases that teach us a lot. And I would like to thank the individual presenters and the discussants. And in keeping with the philosophy of Asia Pacific Ophthalmic Trauma Society, we literally pulled in expert speakers from different parts of Asia Pacific, all the way from Australia, Indonesia, Philippines, and Singapore, of course, and all the way up to South Africa, Dr. Sanushka Murli. And the idea of all these sessions is we learn from each other so that we can serve our patients better. So thank you all once again, and hand you over to Dr. Rupesh Agarwal, who will be the moderator for the session and introduce some of the speakers.
Thank you very much, sir. And thank you, Dr. Natarajan. Thank you, Dr. Rajiv. Thank you, Dr. Ganga. Without further delay, we'll get started. And in this session, what we have done is we have put together 4 different presentations by 4 different speakers and followed by 4 discussions. Each particular topic will be 15 minutes, split into 7 minutes and 8 minutes. 7 minutes is the presentation of a video. Either it is a recorded video or some of the presenter might present a live video. After that, the discussion will probably discuss and give some of his expert comments. And at the same time, we will try to take up the questions which are there in the chat box or from our audience. We'll start with Dr. Sabir Kazi from Bangladesh, who will be speaking to us, and all of them are the members of Asia Pacific Ophthalmic Trauma Society. We'd like to thank each and every one of them for contributing their time, particularly on Sunday afternoon, Sunday evening, and the different times of the zone they are in. So Dr. Sabir to present on smaller does not mean easier. And Dr. Purindra Basin from India, Gwalior, will be the discussion for his video. Dr. Sabir, over to you.
Thank you very much. Thank you very much for the invitation. And I'm really, really grateful that you have allocated a little time in this August meeting. I'm a pediatric, I'm sorry. Can you hear me?
Very clearly, very clearly. Okay. You go ahead, yeah. Yeah, Dr. Sabir, we can hear you.
Sorry, video to pause.
The video is going on. We can see the video as well.
So this is a traumatic case and of a 4-year-old boy, and who was referred from the village, and it was we call it Danguli, and it was a really, really shallow anterior chamber, an absolutely fibrous anterior capsule with some sort of people was not being dilated at all. And then we tried to do start this cataract surgery, but first, due to very shallow anterior chamber, we had to close the first wound, and then we had a second entry wound with some Trifine blue. We tried to take some cortical matter from the capsular bag. It was fibrosed to dampen the intralenticular pressure, because the maneuver of any instrument was not very easy at the time of surgery there. You see, I was trying hard to take some cortical matter, and after trying a little bit time, we could really remove some sort of cortical matter, and then use a curved scissor, and along with the straight scissor and also the capsular excess forceps to complete the anterior capsulotomy. And it was about to complete a nearly circular anterior capsulotomy, and then use all the means to clear the cortical matter, and also to polish the anterior capsule and the posterior capsule with bimanual cannula. And they see the the capsule was cleaned, and the capsular bag was really freed from all the fibrous cortical matter. And finally, the lens was introduced in this shallow anterior chamber. Initially, the case was that, and with using the burger space, introducing some sort of viscoelastic under the lens, the posterior capsulotomy was done. And then finally, after the posterior capsulotomy was done, anterior phase of the vitrectomy was completed to complete the surgery. So just if you go back to the first picture, I mean, the very initial stage with a very shallow anterior chamber where there was no hope at all, and that was referred to us from a village hospital to have to help the child. And finally, this traumatic case was completed with this sort of clear visual axis. And this child had, after that, with correction, 6/12 vision. And now the second case, please.
Can we play the second video?
Second video?
Ankit, can you play the second video?
Second video?
Yeah, it's coming up.
Oh, this is it. This is another traumatic case where there is no anterior capsulotomy, anterior capsule here. There's a fibrous band here, and it was not easy to really decide what to do, to cut the anterior, cut this fibrous band or not to do it. And here is absolutely full of vitreous. So I use my vitrectomy port to take the vitreous and also to clean the cortical matter. I caught the posterior capsule here, you see here, but it has to give some time to let it go. Yes, it freed the posterior capsule, and then keeping this fibrous band, I decided not to cut it, but to complete the other steps, to complete the basic steps of pediatric cataract surgery, to use this fibrous band as a scaffold, because I had no 3-piece lens at the time. And so I introduced the lens into the bag with the help of this fibrous band and complete the surgery. With these 2 videos, I really like to say thank you very much, and end of my presentation.
Thank you, Dr. Sabir. And these were excellent videos. I will like to now invite my very dear friend, Dr. Besin, who is the Secretary for Ocular Trauma Society of India, and one of the very prominent names when it comes to the traumatic cataract. And I have seen his videos, so I always give people advice to don't follow his videos without any learning from him, because he gives lots of very complicated surgeries. So Dr. Besin, over to you for discussing.
Thank you, Dr. Rupesh and Dr. Ganga, and thank you for the introduction. I really would like to appreciate the work of Dr. Shabir, Dr. Shabir Kasi. He has done both the cases beautifully managed. Let me first focus on the first case, which is post closed globe injury. And that was a case with the band in the iris. Probably there is a rupture of anterior capsule, and there is an iris defect also, what I could see, because temporarily the iris was not complete. The pupil is not round, and that's what I have observed in it. There are 2 challenges which he has managed very nicely. One is the presence of fibrous band and the inflammatory membrane, which he has peeled off initially, and the fibrous band also he has maintained it till the end. But my different point of difference would be that at the end, when I am sure enough of the placement of the lens, then I would have definitely removed that fibrous band at the end of the surgery before leaving the patient out of table. And this PCR, which has occurred during the inadvertently during the vitrectomy, which is there. So what I would have done is that I would have not left this fibrinous band. I would have used a triamcinolone to stain the vitreous which is there in the anterior chamber, and so that there is no tag of the vitreous present, and it is not carried along with the lens, and lens placement is perfect when there is a placement of when there is absence of vitreous. So these are the 2 things which I would have done differently. and otherwise he has managed the case very beautifully. The other case, the very first case, is again a closed groove injury, hypermature traumatic cataract with fibrosed anterior capsule, presence of posterior synechia with a very small pupil, and there is he has done it by doing a synecholalysis, used iris hooks to dilate the pupil, and both the cases were of pediatric age group. He has highlighted the technique of aspiration of fluid lens matter from within the interlenticular space by the needle. Although this is tricky and it should be done by experienced surgeon because there is a chance of rupture of the anterior capsule or extension of the anterior capsule tear to the periphery. So it has to be done with a pinch of salt and cautious. And he has shown the trick of how we can do posterior capsular axis with the help of vitreous cutter going underneath the IUL after placing the IUL in a shallow anterior chamber case. And this is also very beautifully done. So this is a very, my point would be that we could have, if available, we should use a high viscosity viscoelastic material like Helon or Helon GB to deepen the chamber in such cases. And then this is what it is required in this case. And otherwise it is, he has managed the things very nicely and highlighted few things how we should do it. Thank you.
So Dr. Purendra, thanks for your very good comment. And I just wanted to understand from you, let's say you are an experienced cataract surgeon. So this surgery should be done by experience, or someone who has a limited experience. Can they manage it? What do you recommend? Because it comes to different ophthalmologists. At what stage? Because you don't want, you really want to help the patient. So what should be your recommendation?
It should be done by experienced surgeons. That is what, and who has got ample experience of managing pediatric cataract and experience of managing traumatic cataracts.
Yeah, I think that's a very important point also for the listening audience. It's like sometimes you have to kind of refer this to the complex cataract team because there can be more complications as you go along. And
absolutely.
Yeah. Any other panelist on the board has any specific points? We have 2 minutes to go to the next case. Dr. Ganga, Dr. Natarajan, Dr. Raji.
Invite Dr. Watson or Dr. Sanushka to make a
quick
comment. Dr. Watson, please.
Yes, they're very interesting cases, can be very tricky, and I think it's very resourceful to try to use what tissues you have that are there. I mean, in repair of ocular trauma, we try to keep as much as possible. You don't want to sort of excise things that might be helpful, so that the fibrous band sort of fits in with the principles of ocular trauma repair. Obviously, if it's necrotic tissue, we do have to excise it, but we mostly try to keep what's there.
I think that's a very good point. And here we have Dr. Vivek as well. You want to make any comment?
I just wanted to ask a question. Can I ask?
Yes, sir. Yes, sir. Please.
No, to Dr. Anwar and Dr. Basin. Now, I mean, I just wanted to know. I mean, is it safer to do the posterior capsulotomy through the pars plana in these sort of cases? And also the anterior vitrectomy through the pars plana rather than through behind the lens? I mean, rather than going through the anterior segment and going under the lens, do you think going through the pars plana and just doing a small opening and also doing an anterior vitrectomy may be I mean, I just wanted to know, I mean, basically, I mean, is that a better technique or this is the standard technique that's followed?
Definitely. Can I say, Doctor?
Yeah.
Yeah, actually the anterior segment surgeons, they are not well versed with the pars plana and technique, and they are having apprehension in going through the pars plana. So that is the major reason why they prefer going. And if you maintain the anterior chamber and maintain the space behind the lens, and with a good vitrector unit and bimanual unit, you can do it, and we are doing it. But definitely, approach through the pars plana would have been better.
Thank you. And what's the cost for the fibrotic band?
It's a trauma
inflammation,
yeah.
post traumatic inflammation, uveitis. And the tag of the capsule is along with the fibrous band. That is the reason.
That can be removed through a bimanual technique. I mean, using the bimanual, just lifting it up and trying to, is it possible to remove it like that, or it's better to leave it there?
You can
I
do
think
a
we should.
you can use a vitreous forceps and then use the curved scissors from dot to cut it and remove it, so that you can catch it and remove it.
Exactly.
Sorry to
Cutter may not really help to cut this fiber through the parspan is always better, so that you avoid the cornea. And I know, I think you have done a very good, Dr. Kasi, you have done a wonderful job. But I think, yes, Kasi.
Just 1 minute. But I left that band because there was no iris before. It was repaired before. This case was repaired before, and at that side there was no iris. So if I cut it and then even put the lens, it might rotate, and maybe it would not stay in the bag. That's why I decided not to cut the band in this case.
I think that's a very good approach, and I'm sure each case will teach us a lot of things. But time to move on to next case now, and I will request Dr. Ganga to introduce the next speaker in the discussion for this session. And we also want to introduce about our keynote speaker as well, Dr. Ganga.
Oh, okay. Thanks, Rupesh. It's my pleasure now to introduce Dr. Eva Cathedral. She comes from a city called Iloilo. It's a small place, I think, compared to Manila, a zoo like Manila, but she does a lot of complex ophthalmic trauma work. She's specially trained in ocular plastics, does general ophthalmology and trauma, and is also trained in oncology. So a special person. She's going to share an interesting case, a challenging case during the COVID era, which will be discussed by Dr. Sanushka Murli from South Africa, who, once she gets rid of this new variant, is going to be organizing a trauma meeting in South Africa where we'll all be invited to. And it's a special mention that we also have Professor Watson, who will be giving a keynote lecture right at the end. So please, all of you stay around to really learn the tips and tricks and masterclass in corneal trauma. Over to you.
And Ganga, as a president of Apots, I've already agreed to come to South Africa and then go to Whale, Colorado for the whale vitrectomy meeting.
Let's play Dr. Eva's video, please.
Hi, good day, everyone. I'm Eva Cathedral, and I'd like to talk about globe repair in the time of COVID. So let me present my case. This is a 32-year-old male. His left eye was hit by a screwdriver while working in a car shop. He was seen in the emergency room in our government hospital 1 hour after the injury, with note of sudden blurring of vision or loss of vision, and there was note of bleeding. Vision was 20/20 for the right eye, and the left eye was NLP. There was a note of a corneal laceration from 1 to 5 o'clock position, extending 4 to 5 millimeters posteriorly. There was iris prolapse and an 8-ball hyphema. No fracture or foreign body was found in the X-ray. However, the patient was SARS-CoV-2 positive after the nasopharyngeal swabbing, though the patient was asymptomatic. During this pandemic, the hospital protocol for non-COVID patients is to delay surgery as much as possible until the nasopharyngeal swab becomes negative. Only emergency cases were done in the hospital, with, of course, with special precautions. So, because in the ideal situation, urgent wound exploration should have been done and repair of the corneal scleral laceration and evacuation of blood clots and iris repositioning. But in this case, the questions that we were contemplating were, number 1, is the virus present in the eye? How infectious would it be? Number 2, what precautions are necessary during surgery to prevent the spread of COVID-19 to the surgeon and the operating staff? Number 3, can we delay the surgery until the patient becomes negative? And the protocol here is a 14-day quarantine in the isolation facility. And after that, we have a repeat swab after the quarantine. Our swab results at that time are released like after 24 to 48 hours. Number 4, if we delay the surgery, how do we manage the patient for the next 2 weeks? What is the risk for endophthalmitis or sympathetic ophthalmia? Number 5, what are the legal implications if we delay the surgery? Do we have the right to refuse the patient in this time of pandemic? So the patient actually was not accommodated in the government hospital. So corneal scleral laceration was not repaired. He was brought to a quarantine facility for 14 days. And the only meds that he had was levofloxacin 1 drop every hour and an oral moxifloxacin 400 milligrams per tab once daily. He was able to go to the private clinic on the day 21 of the injury. He had no pain nor headache, VA was still NLP, cornea was edematous, but he can still see the anterior chamber. There was no note of hypopyon. The anterior chamber was formed. So what did we do? We did the repair of the corneal scleral laceration. The iris was not reposited back. No, he was put on IV cefazolin and gentamicin, and the post-op meds were moxifloxacin eye drop, levofloxacin, prednisolone acetate, and an oral levofloxacin 750 milligrams for 5 days. This picture is a picture of the patient 1 week post-op with no signs of infection. We had the patient ultrasound, and you can see that the globe is already shrunken and deformed. Actually, this patient is still happy because even if he could not see, he still happy his eye. So more questions were in our mind, like if the vision was not NLP, would the decision to delay the surgery be more difficult? Would the doctor be liable in court for the loss of vision? And number 2, would evisceration or enucleation a better option in this case? Considering that this was already 21 days post-injury, would that help? Because would evisceration enucleation help to lessen the risk of sympathetic ophthalmia? So that's our case. This is our only case that is a COVID positive patient, because the rest were COVID negative. So I would like to hear your thoughts, doctor, about this case. Thank you.
Thank you for that case, Dr. Eva. Very interesting to always see what the different protocols are regarding COVID and emergency surgery across the globe. In South Africa, we're pretty lucky. We get our COVID results between 6 to 24 hours, and every patient with an open globe, we try to manage within 24 hours. So all the patients are managed as a person under investigation, whether they turn out COVID positive or not. So full PPE, precautions taken in theater with regards to surgeon not being present for extubation, intubation, and so forth. And we operate them as soon as possible. Even a patient who presents to you with NLP, especially the ones with 8-ball high femurs, we always give patients benefit of the doubt and manage them as if they have potential vision. So washing out the clot, doing the primary surgery first to reposit the iris and all of that. And then later on, I mean, you said the laceration did extend posteriorly about 5 millimeters. So obviously assessing the patient for retinal tears, need for PPV, and that's usually done within 4 to 7 days after the initial surgery. So we try and manage all of them as if they have potential sight. And obviously, I think in this case, with regards to your question at the end, enucleation and evisceration wouldn't have been an option for me. And obviously, after 21 days, your risk for sympathetic ophthalmia is already there. So doing it at this point wouldn't really change much in terms of the patient's management or risk for sympathetic ophthalmia. But especially with this patient, I think it's important to counsel them because they are at risk and watch them closely or follow them up closely with regards to the sympathizing eye, because you obviously want to catch that and manage it as well as possible, as soon as possible.
Those are very good points, Dr. Sanushka. And Dr. Natarajan, you've raised the hand. You want to say something?
Yes, Ganga. So I think I agree with Sanushka, and I just want to convey our Dr. Ferenc Kuhn and my idea of when there's no PL, with no enucleation, no evisceration. I think we should convey however bad the eye is. And as Sanushka mentioned, I think the protocols may vary from institute to institute, to country, and even state to state. But still, I think after understanding, now we are all vaccinated. I was operating even when we were not vaccinated. So I think we have to be careful when intubating, and probably you can even, what was the age of the patient?
32 years.
32 years. I would have operated without anesthesia, with an intravenous sedation, and probably a peribulbar, not peribulbar, the Van Lins, by not giving a retrobulbar because already it's open globe injury. So I think we should do a good primary wound repair, followed by, as Ferenc Kuhn does, and I'm following, which I did in Kashmir, is 6 days or 100 hours from the primary wound repair. We should do the second surgery, so that there's a possibility. And I think I also want to add that there's a famous story which says when somebody is in coma, if the patient had an option to tell the surgeon, please operate me as though I am alive. Don't treat me as dead. Because sometimes the coma patients knows what's happening around, even though they may not be aware at that time, but subconsciously they know what's happening. So same thing I tell the patient, we'll do the best. The chances may be 1%, but and if you get, there's a possibility, there's a good vision also possible. And I remember a similar patient with an injury, and during COVID I have done 3 surgeries, and I think somewhere counting finger vision is there. She came with a suprachoroidal hemorrhage, and then 3 surgeries done with oil, and under the oil membrane removal, and plus now I removed the oil and also have a cataract with IOL. So I think a good attempt and then a good repair is important.
Thank you, sir. I think Stephanie also has a point. Just before we move to Stephanie, just one point. I think in this context, what Dr. Eva is asking also, the patient is COVID positive, and will your protocol, Dr. Sanushka and Dr. Natarajan, will it differ? Let's say this is non-COVID, we definitely follow Ferenc advice, your advice, and Dr. Natarajan, that no light perception, we can't remove the eye. But in this case, with the COVID positive, how do you kind of justify your points in view of the COVID positive? What's your take on that particularly?
So Dr. Rupesh, in South Africa, we still operate on them if they do test positive, because most of them are asymptomatic positive patients that are presenting. So we manage them as COVID positive, full PPE. They come from an isolation ward, they go back into an isolation ward. You obviously remove your PPE and everything in theater. The theater gets cleaned out basically, but we don't change our management whether they are COVID positive or negative. It's just a matter of the precautions taken.
That's a very, very important point, I think. Stephanie, over to you. You have some points to make.
Oh yes, I was going to say that we have the same approach. We just ensure everyone has proper PPE and protocols in place. But I managed a patient who was in Spain, and he had COVID, and he was wearing an oxygen mask, and the tubing hit him in the eye, and it perforated the eye and got a keratitis. And he then came to Australia, but he was put in quarantine for 14 days. With his eye in this terrible state, and as soon as he got out, we repaired the eye, but it was a little bit too late. So I think there are consequences for these delays, and you have to take precautions and get on with it if you can.
I think very much agree. Coming from Africa and Australia, Vivek, what do you say from South India?
Thank you, Dr. Rupesh. I actually had a different point with respect to the perception of light vision. I have noticed many times for patients who present to you acutely and manage to reach your table well within a short frame of time, the original NPL recording may actually be because the patient is in a state of shock, not really able to comprehend your instruction with respect to recognizing the light. So when you have them on table, if there have been a few hours down the line, things settle down. Many a times that no PL, which was at absolute first interaction, just few hours down the line may actually give you a PL positive or sometimes even hand motions. So there, I think, is a point which Dr. Natarajan was pointing out. No PL shouldn't detest us from trying to go ahead and have an attempt at repairing the injury.
No, I think absolutely agree. There are different reasons why you can get a no light perception, and very rightly you mentioned sometimes it is not recorded properly, or whatever reason the patient is in stress and trauma kind of thing. And also you can get dense vitreous hemorrhage. You can get retinal detachment also, and sometimes transient optic nerve edema and all also can result into no light perception. And with the repair and medications, probably you can get better. Anyone, any final points before we move on to the next case?
I would just like to commend Dr. Eva. I mean, despite all of your challenges, you managed to prevent the patient from getting endophthalmitis. So he's luckily ended up with a pain-free blind eye. So well done.
Absolutely. Just a quick comment, Rupesh, if you don't mind.
Yes, sir.
We just had a Philippine Academy of Ophthalmology meeting on Friday and the trauma session. One of the points that was brought up was, can the OTS be used as a guideline, as a threshold intervention? And I think that take-home message is, even if the eye has only a 1% chance of recovery, functional or structural recovery, we owe the patient that 1%, because to him, that 1% is 100%. So take-home message is positive or not negative. The patient needs to be repaired. This is where we become the advocates and necessary step on the toes of management. Make sure the hospital gives us a permission, take necessary precautions, and repair all these globes. That's just that point. Thank you.
Just to continue with what Dr. Ganga said, even if that 1%, and if we make an attempt, the patients will have a positive psychological impact, because if you go in and then someone removes the eye immediately, the patient will be left into that traumatic mindset for his lifelong. So I think that's going to really cause a lot of damage to him in a long period. So if you give him time, and after 1 or 2 months, if you have to remove the eye for whatever reasons, by the time he's mentally prepared, family is mentally prepared, So I don't think primary enucleation is the way to go forward. Anyway, so we'll be moving forward to even more complex topic, and we can't have a better pair than Dr. Giridhar, who is a well-experienced surgeon as a discussion for this thing, and really one of the leaders for Apots as well, and young, enthusiastic, very highly motivated Dr. Vivek Dave, who has been kind of putting on the group about the clips, which he has very nicely done the work with APU LDP program. So Vivek is practicing at LV Prasad Eye Institute as a trauma surgeon, and he is doing a lot of other translational research work as well. But today we'd like to hear his surgical skills related to posterior segment trauma, and then Dr. Giridhar will comment. But friends who are listening to us, don't leave the hall yet. You will have a very important keynote session, which will be coming from none other than Professor Stephanie Watson from Australia, and which will be on the pulse about corneal trauma management. So I think that's something which you should probably stay on tuned with the Zoom. Over to you, Vivek and Dr. Giridhar.
Thank you, Dr. Rupesh. I understand my video would be played from the audio-visual side.
Yeah.
Hello, everyone. I would like to thank the Kerala State Ophthalmic Society and the Asia Pacific Ophthalmic Trauma Society for giving me an opportunity to present this case of mine. My case is titled Broken, Torn and Bloody, Still Can Be Fixed. I have no conflicts of interest to mention. Coming to the case, this was a 53-year-old male with sudden onset vision loss in the left eye since 8 days. The patient had a history of road traffic accident 8 days ago, wherein he was diagnosed as a case of orbital fracture in the left eye. The presenting intraocular pressure was 0 millimeters of mercury, and the vision was perception of light present and projection of rays accurate. This is what the external examination looked like. If you see, the right eye was normal, but the left eye shows the globe, which was sunken with a lot of conjunctival chemosis around the cornea. The cornea essentially was clear. The fundus examination showed vitreous hemorrhage, and the details of the retina were not discernible. Hence, a B-scan ultrasound was done. If you see here, you can see a reflective echogenic membrane with attachments at the optic disc with poor after movements on dynamic scan, which was suggestive of a retinal detachment. Interestingly, behind the retinal detachment, between the detachment and the coats of the eye, one could see a lot of echoes which were consistent with subretinal hemorrhage. So herein we had a case of orbital fracture with concurrent vitreous hemorrhage, retinal detachment, and subretinal hemorrhage. In view of possible attempts to make a vision salvage, this patient was taken up for vitrectomy. Herein we see the surgical video of the case. A pars planal lensectomy was done first because the lens was seen to be subluxed, following which the vitreous hemorrhage was cleared. Herein we can see a lot of thick clots in the vitreous cavity. As the peripheral vitreous was cleared, we could see peripherally an irregular large retinal tear through which hemorrhage had seeped in the subretinal space. The retina was thrown into folds on the posterior pole, as is visible in the video here, with a lot of bossellation due to the underlying subretinal hemorrhage. Attempts were made to flatten the retina with perfluorocarbon liquid. As they were unsuccessful, a peripheral retinectomy was done all 360 degrees to gain access to the subretinal space. The retina was then folded onto itself to expose the large sheet-like blood clots from the subretinal area, which were then removed using a cutter on suction mode. All loose hemorrhage on the surface of the bare RPE was also removed. After all this hemorrhage was cleared, the retina was now settled with perfluorocarbon liquid. 360 degrees endolaser was done, followed by PFCL air exchange, and finally air silicone oil exchange for final tamponade. 3 months down the line, this is what the retina looked like. We can see that the retina was well attached with 360-degree endolaser visible, a pale optic disc, and a small dry fold extending from the disc temporally just close to the fovea. Vision had improved from perception of light, projection of rays positive to finger counting at 4 meters, and the intraocular pressure had risen from 0 millimeters of mercury to 18 millimeters of mercury. So the take-home learning points from this case for me were that a retinal detachment in a badly traumatized globe can have subretinal hemorrhage. Ultrasound B scan can be a good modality to pick this up. Subretinal clot evacuation is paramount in achieving retinal reattachment in such cases. Limited or a total retinectomy can allow for a clot clearance and may have visual benefit in some cases if the retinal reattachment is achieved. Finally, my questions for the panel are, what would, in your opinion, be optimal timing for taking up such a case for surgery? And second, in your practice, do you assess for optic nerve function before taking such cases up for surgery? And if you assess and if you suspect a traumatic optic neuropathy concurrently, how would you account for it in the final management approach? Thank you very much for your kind attention.
Thank you, Dave. I mean, very nice video. Very nice video. Can you hear me?
Yes, yes, clearly.
Very nice video. I've just written down some points. I think most important points in this case is a very timely diagnosis and management. I think that's very important. I always say in ocular trauma, you have to be at the right place at the right time. That's very important. If you don't reach the right place at the right time, then probably, because the time is very short. You've got only that window period during which everything has to be done. So if you don't reach the right place at the right time in that window period, then unfortunately the patient really suffers.
Sorry, Dr. Girija, if I may interrupt. Maybe the patient was at the wrong place at the wrong time to begin with. Carry on, please. Thank you.
And in this case, clear cornea, good access to posterior segment, then obviously an early intervention. Because when you find an underlying retinal detachment, I don't think there's any purpose in waiting very long as far as a surgical intervention is concerned. Then what was the anesthesia used? Because you have a sunken orbit, whether local anesthesia will work, whether the patient requires a general anesthesia in such a clinical situation, because local anesthesia, chemotic eye, traumatized eye, orbital fracture, etc. Probably local is difficult. Probably I may prefer a GA in case the patient is fit for general anesthesia. Then you have used an anterior chamber maintainer, which probably you didn't emphasize in your video presentation. I think you used an anterior chamber maintainer. That's, I think, a very important point. I think that's that's a very important point, because that gives you easy access both to the posterior segment and to the anterior segment in this particular condition. The most difficult thing, as far as some of these cases of ocular trauma, is the hemorrhage, the dense hemorrhage that we see. I mean, sometimes the hemorrhage is so dense that there's no visual, because this is a choroidal hemorrhage. This is a choroidal hemorrhage that seeps into the vitreous cavity. It's very sticky, it's yellow, it hardens very fast, it stains the posterior capsule. Therefore, in this particular case, of course, the lens is removed. Otherwise, in some of these cases, you may have to remove the lens to get access into the posterior segment. And you have to, unlike a normal vitrectomy, you have to dig inside. You have to just go, layer by layer, and finally see the retina at one particular point, and then slowly, from there on, push separate the blood from the undersurface of the retina and induce the PVD. So we cannot do the standard induction of posterior vitreous detachment in such cases, and we have to be very careful, because you have a detached retina, you have a lot of blood. So that's again another challenge. Probably the way you can just explain as to how it was in this particular case. Then I sometimes mostly use chandelier elimination also in some of these complicated trauma, because one is it improves visualization. Sometimes when you need any bimanual procedures, it's easier to do it. Then drainage, of course, as far as the surgical management is concerned, I think I don't have anything more to say, but whether a limited retinectomy would have sufficed instead of a 360-degree retinectomy, because when I saw one half of the retina was very taut, the other half did not look very taut. So whether the 360-degree was done primarily with the intention of removing the blood completely, or whether the detachment itself demanded such a retinectomy. And then I usually do a PFCL silicone oil exchange in such situations, because more comfortable, but what you did also is a good technique. So these are some of my points, and some of the, I can ask Dr. Natarajan is also there. He is more experienced than me. Probably he may be also able to say a few points before Dave takes over. If he is there, or he's not yet finished his lunch, I think.
Sorry?
Lati has not yet finished his lunch, I said.
Yeah.
So,
do you have any points?
Doctor?
Yeah. Thank you, Dr. Girdhar. That was a very detailed analysis of the case. So just coming to a few of the points that you mentioned, like you said, this case was done under general anesthesia, because a concurrent fracture, attempting a block, you would not know where the block is going, what compartment you are entering. So I think LA would be a strict no-no. GA would be the ideal way to go, unless there are some sort of contraindications. Secondly, I think one point which I could not elaborate in the presentation, possibly I should have, with that sort of sunken globe, there would also be a thought process whether we are dealing with an open globe injury. But if we look at the conjunctiva and the history, I have not dwelled much into it. The history was a fall and sort of rather RTA and a blunt sort of an injury to his eye. Nothing in the history suggested any sort of penetrating wound. If you allude back to the video, the entire conjunctiva was chemosed uniformly. We did not have any localized area where we could see any specific hemorrhage or any extra, I would say, edema. Plus, on palpation, the globe was pretty firm. So from that point of view, it was assumed, or it was clinically concluded that we are not dealing with an open globe injury. Going ahead, the AC maintenance again is a very important point. The main purpose here was because you would expect subretinal hemorrhage, suprachoroidal hemorrhage also sometimes. Even if you use a 6 mm cannula, there is no guarantee that you will be in the vitreous space till you have clarity enough to visualize the tip of the cannula. And as we know in retina, if we are in the wrong place and we put the infusion on, we may just change a salvageable case to a non-salvageable case by adding more caveats to the case. So from that point of view, I started with the AC maintainer, but I usually shift Dr. Giridhar back to a cannula once I am at the stage where now I need to put oil. Because in my experience, when you fill oil with ACM in place, at that final step of removing the AC maintainer, oil tends to come towards the anterior chamber, and again, it might mess things up. So here, the ACM was shifted to a 6 mm cannula at the last step. And lastly, like you mentioned, possibly 180-degree retinectomy could have sufficed. I think I possibly may have overdone it from the point of view of having that security that if I cut retina 360 degrees, probably I would not have any sort of subclinical traction left behind. I think that is what was the philosophy with which I did 360. Yeah, thank you.
Thank you very much, Dr. Vivek.
If you want to say anything?
Dr. Natarajan, you have 30 seconds to say.
Yeah, okay. So I agree. I also do a lot of things with AC maintainer. Great surgery. I saw that, and I agree with the Giri also. But the main thing is sometimes I've done entire procedure with the limbal approach, the AC maintainer, the light pipe, as well as the cutter, because sometimes we can't make out everything is disorganized. So I think as Rupesh said, only 30 seconds, I think what you have done is wonderful. Finally, the outcome is important, and we have to keep the best outcome in mind and do all these crazy procedures.
And Dr. Vivek did ask about the optic nerve function. How I don't know whether I missed Dr. Giridhar, your point on that.
No, I didn't elaborate on that. I thought Ganga is a better person to elaborate on that.
Dr. Ganga, sir, you want to say something on that optic nerve function? How do we assess, and will it affect our management?
One, it doesn't. But most importantly, when you have a significant globe injury, traumatic optic neuropathy doesn't exist. We have to presume that all visual loss is from the globe injury. So you should manage it the way it is, and you should not waste time either in doing electrophysiological tests. I assume that CT scan was done, but it's not shared, but that should give you both a global picture of the globe itself and the orbit. So you know when you're manipulating it. But just one quick point, just because it's a blunt injury does not rule out an open globe injury.
Yes.
Yeah.
So that's a very important point I thought I wanted to just get across. Thank you.
And just to continue with what Dr. Ganga said, picking up RAPD, relative afferent pupillary defect, does not mean that there is an underlying optic neuropathy. And though there are more than 5 or 10 publications I remember, which has shown there is a reversible RAPD. Once it is set up, it's not like it is written in it's permanent. You can still get. So that's not a very kind of a strong sign. Electrophysiology, as Dr. Ganga very rightly said, it's not going to probably help, and it's not going to change your management. That just because you get a flat electrophysiology, we have cases where there was a flat electrophysiology, you still get recovery of those cases. Dr. Purindra, one very quick comment, and then before we move next.
I think orbital management, because there was a sunken globe. So what was the cause and how was it managed? So that's what I think it would have been managed in a second stage. Or what was it?
Yes, Dr. Basin, the patient is now with our oculoplasty service, and he's being assessed for the fracture management. Once that settles down, he would also be around 5-6 months down the line in follow-up. 5,000 centistrokes oil has been filled. That is when we will plan the silicone oil removal if the retina holds on.
Thank you. And CT scan is, I think you must have already done it before proceeding for the case.
Yes. I am apologize. I could not pull that out and sort of share it here.
But that will give us the whether it's a open globe injury or ruptured globe posteriorly.
Right. The CT scan did not reveal the globe to be open. So I mean, yes, we possibly cannot rule out occult tear. One school of thought would be that you should actually explore the globe, but then with a sunken globe, is a part of the globe sunken into the open sinus through the fracture, it might make exploration, worsen the situation. So from that point of view, an exploration was not attempted in the primary go.
Thank you.
I'm sure we have many things to discuss. Over to you, Dr. Ganga, to invite our last thing before the keynote.
Sure. Thank you, Rupesh, and all the discussants and presenters. Apots, as you know, is an ophthalmic trauma society, and ophthalmic is ocular and adnexal trauma. In my opinion, no trauma session is complete without addressing adnexal structures. So we now have Dr. Purjanto Tipo from a beautiful city called Yogyakarta, very close to where the famous Borobudur temple is. It's one of the man-made marvels of the world. You should go there and eat the food as well. Enjoy the hospitality. Who's going to challenge it? Presenting a challenging orbitofacial fracture, which will be ably discussed by a good friend, Dr. Farzad Patel from Tehran, Iran. Extremely experienced, will be discussing the case. Let's play Dr. Purjanto's video, please.
Hello, everyone. First of all, I would like to say thank you to the committee for inviting me here. It's such an honor for me to be here in the Apots meeting. And today I would like to present my case about the challenging orbital fracture. I have no financial interest in this presentation. As we know, the orbital fracture accounts for about 3% of all emergency cases following mid-facial injury. And orbital fractures can lead to aesthetic deformities and functional impairment. Spectrum of orbital fracture includes small fractures to a complex orbitofacial fractures. And the management are still debated in various aspects, such as the indication for surgery, the timing of surgery, and the best reconstruction material. And the practical classification for this orbital fracture, there are two classifications. The simple orbital fracture, if the fracture involves one or more walls without involvement of orbital rim, it can be linear fracture, blowout fracture, trapdoor fracture, and blow-in fracture. And second, the complex orbital fracture, if the fracture involves one or more orbital walls with involvement and displacement of the orbital rim. It can be zygomaticomaxillary complex fractures and also naso-orbital ethmoidal complex fractures, also cranio-orbital fractures, commonly orbital roof, and orbital facial fractures consist of Lefort 2 and Lefort 3 fractures, and also panfacial fractures. They consist of upper face, mid face, and lower facial fractures. And the management of orbital fractures, which are minimally displaced or small, without herniation of or entrapment of content, may be managed conservatively. And all significantly displaced orbital walls, with or without rim involvement, with prolapse of orbital soft tissue, generally require surgical intervention. And this is my case. A 40-year-old man came to clinic complaining about the right eye could not be closed properly. About a month ago, he had a motorcycle accident. And then he go to the nearest hospital and surgery was done. The surgery was to close the wound in the eyelid and also putting a plate on the maxillary bone. On the day he came to the hospital, the general condition was good. The visual acuity of the right eye to over 60. The inferior eyelid, there's a retraction, lack of thalamus, and there's synophthalmos. There's a conjunctival hyperemia, corneal keratopathy, the anterior chamber deep and clear, the iris round at central with 8 millimeters in diameters, and the fundus is normal, and the eye motility restricted to all directions. From the first surgery done by the doctor at the first hospital a month before, they closed the wound and placed a mini plate in the nasal bone to zygomatic bone. From the CT scan, we can see that there's a comminuted fracture right zygomaticus bone and bilateral nasalis bone fracture, left maxillaris fracture, comminuted fracture of the anterior and lateral wall of the right maxillary sinus, and also mini plate. We diagnosed this patient with severe right zygomatico-maxillary complex fracture. And the problem of this patient was the severe right zygomatico-maxillary complex fracture. And this is the old fracture. It's already 4 weeks. And the entrapment of the orbital soft tissue, and also the malar hypoplasia and enophthalmos. We do the second surgery 8 weeks from the first surgery. We remove the plate and change with the titanium mesh to elevate the cheek. And then we correct the cicatrix and do the flap and also lift the cheek. But the result was not satisfied because the cicatrix was not corrected and the cheek still depressed. But now we can see that there is still a fracture of the nasal bone and also the zygomatic bone. It's not corrected. And from this scan, we can see that there's still comminuted fracture of the right zygomaticus bone, bilateral nasalis bone fracture, left maxillaris fracture, comminuted fracture anterior and lateral right maxillary sinus, and also breaching mini plate. And for after 4 weeks after the second surgery, we did the skin flaps and oral mucus graft to correct the lack of thalamus. And the result is not satisfied. We still found that deep superior sulcus and also there's a lack of thalamus. The follow-up after third surgery, the visual acuity become head movement, and there's a hypoglobus and endophthalmos. There's a hyperemia of the conjunctiva, keratopathy, and the cornea. And we can see that the bulbous oculi motility eyeball motility was restricted to all direction. The question for this case is what and how to prepare primary reconstruction planning to achieve the best result. And when is the best time to do the secondary reconstruction for the old fracture? And what is the best technique to achieve the good result? And what is the implant material to give the best result? I would like to thank to all the senior in here who helped me prepare this presentation. Thank you very much.
Dr. Farzad, would you like to discuss this case? If not, can we play his...
Hello? Hello?
Yes, Dr. Farzad, are you there?
Yeah, I'm here. I cannot start my video, so
Can
thank
we
you.
start this video, please? Yeah.
Yeah, please start my video.
And thanks, Dr. Purjanto, for sharing that challenging case. It's not an uncommon situation that we all face. Host, can you play the video, please?
Hi, Ganga. I could start my video now.
Yeah,
So,
go ahead.
Dear colleagues, it's a pleasure for me to join this wonderful meeting. I also would like to thank Dr. Ganga, Dr. Natarajan, Dr. Chi, and Dr. Rupesh for inviting me to this session. Dr. Purjanto made a very beautiful description of a challenging orbitofacial case. I have no conflict of interest, so I would like to start my discussion about this case. Dr. Purjanto showed us the management of a 40-year-old man with complex orbitofacial fracture and ZMC fracture. The last is first. The questions that Dr. Purjanto asked included the actually technique and planning for primary reconstruction of this case and the timing and technique for achieving a good result, and also the question about the material for this case. So we know that zygomatic bone actually has 3 main attachments to the facial bones. And this is essential to understand about this case when trying to make a good plan for this case. So this is the CT scan after the first operation showing us that the zygomatic fracture is a communicated one. And the primary surgery did not address properly about the medial fracture, and also did not address the buttresses, including the ZF and maxillary buttresses, and also missed the NOE fracture in this case. Dr. Purjanto mentioned about severe eye retraction movements in this case. Although we cannot make sure based on the available data about the neurogenic or myopathic reasons for limitation of motion, it seems that the restrictive pattern of movement is the main reason for this case when looking at the CT scan and seeing that scar tissue between the globe and the fracture site and entrapment of the orbital soft tissues and lower eyelid soft tissues in the fractured part. So the primary surgery included just putting a mini plate below the inferior eyelid rim without any reduction, without any releasing of the entrapped soft tissues, and apparently missed the basics of the ZMC repair, fixing the buttresses after releasing the bone and soft tissue. And also we can see here we have alveolar fracture that was obviously missed in this case. And also they missed the orbital floor reconstruction. And this is the questionable part for me, that maybe the zygomatic arc has been fractured and not addressed properly. So we are seeing fixed eye in the adduction and chemosis and red eye, showing that perhaps we have a poor bells and lower eye retraction causing lag ophthalmos and exposure carotid body for a patient. And look at this scar over the cheek. It can remind us that maybe this is a part that was caused by the trauma, but also maybe the first surgeon approached through the same area for putting the mini plate over there, and this could perpetuate the scar formation and lower retraction after the main trauma. So look at all of these things. We are seeing that the lower eyelid has been pulled down, the malar eminence has been lost, and it has been rotated posteriorly and inferiorly. And also, when looking at the CT scan, you may see that the vector of the traction of the lower eyelid is compatible with the fractured site and entrapped soft tissue over there and the mini plate per se. So in the second surgery, colleagues tried to remove the mini plate and exchange it with the titanium mesh, aiming to elevate the fracture site, probably the eyeball, and also made a cicatrice revision, but apparently it failed. And what is the reason for failing the problems in the second surgery? First, we needed to make an osteotomy to remove the bone particles, to reduct entrapped mid-face, orbital, and lower eyelid soft tissues from the fractured site. And after the appropriate reduction, we had to actually appropriately fix the zygomatic bone at least 3 or 4 points to make sure that we have a good position of the zygomatic bone and elevating and bringing in front the bone. So just doing skin flaps without releasing of the scarred middle lamella septum it is not working in this case. Timing of surgery for us, as a general rule, we know that the surgery after the ZMC fracture should be done as soon as possible, but not later than 1 to 3 weeks. For revision surgery, we have no cutoff point, but as soon as we can do it after the primary surgery is the best before fusion of the bone and severe scar formation is more appropriate for surgical outcome. I also would like to remind about the orbital reconstruction and necessity for NOE fracture, alveolar bone fracture in this case. So for rigid stabilization, I prefer the titanium mini plate system. That's standard of care for ZMC fracture. And it's very important to fix all unstable particles in the ZMC fracture. After the third surgery, that actually colleagues made skin flaps and oral mucosal mammographs to correct the lag ophthalmos. What's the reason for failure of this third surgery? Again, the same thing. The hard tissue and soft tissue should be appropriately addressed and corrected. Without understanding that and appropriate technique, we cannot correct the lower eyelid positioning. The eyelid retraction was the result of the maxillary and zygomatic inferior and posterior displacement, medial lamellar scarring, and also skin scar, not just actually posterior lamella. And also, I'm doubtful about any significant scar on the posterior lamellar and the actually use of the column-mucosal membrane graft in this case. I would like to thank Dr. Purjanto for sharing this wonderful, interesting, instructive case with us, and also thank you all for listening. We'll be happy to answer further questions if there's any. Thank you very much.
Thanks, Farzad. That was an exhaustive review of a very complex case. And like I mentioned earlier on, it's not uncommon that we see these situations where sometimes a craniomaxillofacial surgeon takes over the case, ignores the globe, does not address the orbit, but just fix the face. So with your permission, Rupesh, I'll just share one slide with learning points about the case. In terms of principles of management of orbital and orbitofacial fractures, as we well know, life is always first, and next comes globe. And to me, the globe is equivalent to the brain. Just as how brain gets a lot of priority, I think the globe should get a lot of priority. And in this situation, the poor vision says that globe itself was not managed, and then and only then the orbital or facial fracture should be fixed. We already, Dr. Purjanto and Dr. Farzad talked about the orbital versus orbitofacial fractures. Pure orbital fractures only are about 20 to 30% of all the fractures, and 70% of them are orbitofacial fractures. And hence that has to be managed comprehensively. The important take-home message is it's always open, reduction followed by internal fixation. And I think Dr. Farzad mentioned about it. It's not just opening and internal fixation. So it's an ORIF, not an OIF. And that's very important. That's been demonstrated in this case. You have to always address both the soft tissue and the bony destruction that happens. And oftentimes you have to address both issues, sometimes initially the laceration repair alone, followed by the fracture repair, and along the laceration repair is where the globe should have been managed, followed by the fracture repair, and finally fine-tuning. And we have addressed this in our SSOPRS webinars. Like a lot of things in life, the first time is the best time, whether it's an open globe injury or the fracture repair. And I think that's very important. That's where Dr. Rupesh talked about who does these procedures. The senior most experienced orbital surgeon or ophthalmic surgeon is what is most important. Revision, doing it the second time around is always more challenging. You never get a chance to get it right like we do the first time. But principles of management or revision fracture repair is always, you have to undo the damage that was done with the first repair and then redo the repair. I think that's very important. And finally, the take-home message for us ophthalmologists is work and be part of a multidisciplinary team where the ophthalmologist co-manages these patients with an orbital surgeon or oculoplastic surgeon, who in turn works with the craniomaxillofacial surgeon. Thank you very much. Over to you, Rupesh.
Thank you, Dr. Ganga, Dr. Farzad, for absolutely brilliant discussion. I really impressed with this. And of course, our Dr. Purjanto from Indonesia for presenting this complex case for discussion. I think we are really very thrilled with the adnexal, the globe trauma, and then the retinal and general trauma. I think this is really covered in 1 hour, whatever best we can cover, the best of the cases. I would like to thank all the discussants and all the presenters for really making this session very lively. But I think unless we hear from one of the masters on cornea, I think this session will be incomplete. So it gives me a great honor rather to present to you the keynote speaker for the day, none other than Professor Stephanie Watson, whom I know more like a colleague and a collaborator for the trauma initiative through Apots, which is called as IGATES, International Globe Adnexal Trauma Epidemiology Study. And I've been learning a lot from her during that exercise. But just for this session, I wanted to introduce everyone. And she's no kind of a very known, renowned figure in the field of cornea. And of course, to these Apots members, she's not definitely knowing to everyone in the Apots field. She is practicing in Australia, Sydney, at Sydney Eye Hospital, a senior consultant there. She has expertise in both children and the adult corneal diseases, and having completed her fellowship from Moorfields Eye Hospital and Manchester Royal Hospital with her PhD in developing novel dry eye therapy. She has been the international lead in the research and the innovation, and also been appointed as a professor at Safe Sight Institute. She has more than 200 publications to her credits, many international patents, and has been invited to speak internationally, and also the advocacy chair for ARVO. She has been multiple appointments in Sydney, and she's the chair of Ophthalmic Research Institute of Australia, chair of Advocacy and Research Outreach for ARVO, as I said earlier, editor for Cochrane's Group, and also a member of RENSCO. She's been awarded many awards, but just to list down a couple of them, one is the top 100 women in ophthalmology in 2021 Power List and Dorothy Potter Medal, and besides many other awards to her credit. I think if I continue to speak about her, that itself can become a big lecture. So over to you, Stephanie, for the lecture. And I know it's quite late there in Sydney. Thanks to you for staying awake for us and educating all of us. Thank you very much.
Thank you very much for those kind words, and thank you to the Kerala Ophthalmic Society for inviting me, and Dr. Ganga as well for his hard work in putting together the session. So my talk is going to be about lessons for corneal trauma, things you can learn from research and practice. Sorry, my video's just gone off. And why are we here? Well, that's because corneal blindness is still a common reason for people to lose sight, and it can affect all ages, and blind children are particularly impacted as they have a long lifetime ahead of them of poor vision. And corneal scarring has been recognised by the World Health Organization as a priority eye disease. Now, where does corneal trauma fit into this? Well, it's actually the second most common cause of corneal blindness. And in the developing world, in some cases, there's a silent epidemic. Sometimes minor trauma can lead to loss of vision due to infection and delayed treatment. Now, you may remember this surgical sieve from medical school, and showing you how important trauma is, it's actually at the top of the mnemonic, T for trauma. So we've been doing research into trauma at the Sydney Eye Hospital, and one of the things we looked at is corneal foreign bodies. We wanted to understand a little bit more about what happened and whether there are any lessons from our research that we could put into practice in the clinic. In 2016, we conducted a large retrospective study, and that included 723 patients. Interestingly, 92% of them were male. The mean age is around 34 years, but all ages were represented from 11-year-olds to 85-year-olds. And 7 patients had bilateral foreign bodies, so always look at the other eye. Amongst the risk factors was a past history of corneal foreign bodies, so people that had had one may have more, and they don't seem to be learning about how to avoid them. And one of the things we found is that not all patients were wearing the appropriate eye protection. And patients also presented late. And if you presented late, you had a higher risk of keratitis. So with a corneal foreign body, it's best to present within 24 hours to reduce the risk of keratitis, and you can give prophylactic antibiotics. If you're trying to heal a defect, an eye pad, a contact lens, or an ointment has about the same effect. But you probably want to avoid a contact lens if there's any risk of infection. We also looked at our open globe injuries, and what we found is we had around 200, and from this case series, in the elderly, they mainly had an open globe injury if they'd had previous surgery, and this was typically related to the elderly patient falling over, whereas young patients unfortunately had open globe injuries related to alcohol or workplace injuries. So the lesson here is, for patients that have had ocular surgery, we need to warn them to be careful as they're at risk of ocular trauma with falls. Now, for our open globe injuries, we found that the initial vision was really quite predictive of the final vision. So in cases where you can't calculate an ocular trauma score, the patient could be counselled on their outcomes based on their presenting state or vision. And patients that have an intraocular foreign body can do particularly poorly. Again, in this series, we found that safety eyewear did not always provide protection. In some cases, it broke or it wasn't adequate, it wasn't appropriate. So what do we do once we have a corneal injury after trauma? Well, the principles of repair is to really restore the globe and try to return the anatomy. And you need to minimize the risk of complications while doing this. If you preserve the eye, you have the best chance of restoring vision. And one of the techniques that we use in corneal repair is corneal gluing, which you can either do by applying the glue directly using an insulin syringe onto the cornea with the patient lying down. You dry the leaking area first and then you place the glue, or you can make little patches out of a drape, put the glue on the drape and on a cotton bud with some ointment, and you can then apply the glue with the patient sitting up at a slit lamp. Now, we looked at the results of corneal gluing, and what we found is that it was generally effective in stopping leaks at day 1. So 91% of eyes were healed, and this is if only there's a small perforation. It's typically less than 2 millimeters or 1 millimeter. But most of the patients required further treatment, either another gluing or corneal graft type procedure. We had an interesting case where one 67-year-old female who had glue applied for a perforation still had the glue stuck on the eye at 5 years and 3 months afterwards, and we took them to theatre for a planned removal. So if you're gluing for corneal repair, remember it's mainly a temporizing procedure. Over 50% will require definitive surgery. So when you're gluing, you might want to make a time and a plan as to how you will then proceed to repair the cornea more definitively. But in some cases, it can be the sole treatment and it can remain on the cornea for some time. Now, a form of trauma that we see here in Sydney and in Australia is surfboard trauma. And we found in a review of looking at surfboard trauma that surfers are typically injured by their own board. And this is mainly from the nose of the board, the very tip here, or the fins. And it's because the surfers have a leash that straps the board to their ankle. And so when they come off, the board can then be brought back to them so they don't lose the board. But at the same time, it can also bring the tip of the board or the fins in contact with the eye. And these sort of injuries have a very poor outcome. They usually involve the posterior segment, there's globe rupture, and there can be infection. So these are some of the ways that have been thought of to possibly prevent trauma from the surfboard, but it won't help against this sort of ocean menace. So now we also looked at our pediatric ocular trauma. And here we found that, again, there was a predominance of male patients. Presenting visions were generally poor and reduced. But this picture here tells you what we found and what are the risk factors. Well, we found that, again, males were more prone, and you were more at risk of having a pediatric ocular trauma if you had more than one male child present and if they were playing with sticks or stones. Now, for pediatric ocular trauma, the initial vision was also a predictor of final vision, though around 2/3 did achieve a vision of 6/12 or better, and this was more common with a closed globe injury. There were some cases, sadly, of evisceration and enucleation, but this was not frequent. Now, as I mentioned earlier, infection after trauma can lead to loss of sight, and this is particularly devastating for the elderly, as 10% can lose the eye, and in children, they have lifelong amblyopia. It's been proposed that corneal ulceration or infection is actually a neglected tropical disease, and more needs to be done to prevent eyes lost from it. We identified that there were many species that can cause keratitis, and we repeated our search recently, and we found an even greater number, and this can include fungi, bacteria, amoeba. And in our series of acanthamoeba keratitis, we found trauma a risk factor. In pediatric microbial keratitis, 1/5 had a history of trauma. Now, when we have a case of keratitis and as part of our ocular trauma management plan, we need to try to identify if there is bugs or bacteria. And one of the ways to do this is by performing a corneal scrape. And what we did is we looked at the necessary steps that you need to do to perform a successful corneal scrape and produced this video. We found that it's important to take the plates out from the fridge before you do the scrape. It's important to sample at the edge where the organisms are dividing. And when you're placing the blade on the agar plate, not to cut it, but just to stroke it on the top. Otherwise, you'll bury the organisms and you may then miss some aerobic organisms. We've also recently looked at fireworks and ocular trauma. And what we found is that they can cause severe vision loss. And fireworks can be part of festivals around the world. Our study included a number of countries, and injuries were found that were mainly most severe if they were penetrating or if there was injury to the lens. Clearly, more work needs to be done to prevent trauma from fireworks. So how do we prevent trauma? Well, we need to know more. And one way we can find out more is looking back at history. And in history, there's lots of lessons as to how we might prevent ocular trauma and also on the importance of ocular trauma. Now, King Henry II, he had an eye injury while he was jousting in 1559. Jousting was a common sport at the time. They did wear protective gear, but unfortunately his visor wasn't fastened, and at the end, the lance entered through the orbit and bits of wood were retained. He went on to have an interhemispheric emphysema, an infection, and he actually ended up dying from his ocular trauma. This then led to periods of unrest and the religious wars across Europe, and it really changed the course of history. Looking back at eye injuries across time, military injuries have also been important at various stages, and various forms of eye protection have been developed to prevent them. But we need to know more. We need to know what's happening now. And one way we're planning on doing this is through the iGate study. And this is the International Globe and Adnexal Trauma Epidemiological Study. And here what we're doing, and anyone can be part of it, is collecting data on trauma from across the globe. And this is to better understand why it occurs and also how we can manage it. In this recently published paper, we found that people had a higher risk of severe vision loss after trauma if they were female, of older age, had zone 3 injuries, the eyelids involved, and an intraocular foreign body. So ocular trauma, what lessons do we have for practice? Well, unfortunately, it's still a significant cause of vision loss in both adults and children. We need to watch for infection. You need to consider prophylactic antibiotics, and if there are signs of infection, then go to investigation quickly using appropriate techniques so you have the best chance of identifying any bacteria or other organisms. We need to understand how these injuries are occurring to develop better means of prevention. That seems to be a trend in our data so far that safety eyewear has a role, but it may not be being used properly. We may still be back with King Henry II and people losing sight despite wearing some protective eyewear. Thank you very much. Thank you. I'll stop my share.
Always great to hear from you. And I really like to thank for presenting some of the very key points in the management of corneal trauma, keeping it simple, but I am sure it is quite essential for us to manage the corneal trauma in the practice. Any points, any comments from any of the panelists, including Dr. Ganga, Dr. Basim, Dr. Samiksha? Any points you would like to say? Anything to further add on to a very excellent lecture by Professor Watson?
Rather than a comment, I just wanted to thank her personally for readily accepting our invitation and putting together historical perspectives. And sometimes she's probably making us sometimes feel like King Henry.
Yes.
Because we all behave rashly and are involved in risk exposure activities. So thanks for reminding us we are all royalties. Well, over to Dr. Tanushka.
Thank you for that, Prof. Watson. It's actually nice to see when things are quite similar across the globe. And I do a lot of anterior segment trauma, so I've had a lot of experience with glue. Glue is actually my go-to in the rooms to just buy me some time until I get to theater. And a lot of the times, like you say, if the tissue manages to heal underneath the glue, that glue just pops off. But I've found patients that it's actually hung on until I've taken them to theater. And it's really the patient as well feels very happy that you've sort of saved them for now, instead of knowing that they've got a hole or a gash or a gape in the eye while they're waiting to go to theater. Because I think that can also lead to a lot of anxiety where they're worried about losing their eye, losing their vision in that time before they get to theater. And also with regards to fireworks, something we very often see in our December and January period when people are celebrating Christmas and New Year, as well as Diwali in South Africa. And a lot has to go into prevention. Prevention is the only way to sort of minimize these incidents. And a lot of the time, as much as we try, we still see kids going to light fireworks, holding them in their hands. And as much as the parents are informed, I think a lot of the times in our households in South Africa are very young. They're led by young children and young adults, and there's not much supervision that happens in the home. So with regards to that, it's something that definitely needs to be seen to here as well. But thank you so much for a very good talk.
No trouble. Yes. Yeah, here we've banned fireworks here. So it used to be a big problem, but the ophthalmologists petitioned government and we got them sort of banned for better or for worse, but it has been.
Oh, that's great.
That's
great.
Vivek?
Yes, Dr. Rupesh, I hope I am audible.
Yeah.
Yeah. Thank you, Dr. Watson, for that wonderful talk. I had a two-pronged question, actually. In situations of corneal tear where you find an actual tissue defect which you cannot really close, so how do you approach those cases? That is point one. And second, once everything is done and dusted and things are really settling down, with respect to visual rehabilitation, what has been your experience with respect to contact lens rehab vis-a-vis requirement of penetrating keratoplasty in second stage?
Yeah, so when you don't have the tissue, you can, in the first instance, if it's an emergency, just try to stitch it together as best you can. I mean, this can really distort the cornea and make it really flatten out, but at least you've repaired the hole in the eye, and then you can plan for lamellar grafting or corneal grafting. I mean, to get corneal graft tissue here, we can't get it straight away. We can get lamellar graft tissue. And if it's a small area, that might be suitable, but I would sort of do whatever you can to repair it and then sort of make a more definitive plan. And corneal grafting, if you have a scar and after trauma, it can be done. I think it's the same principles that the patient has to be understanding that it's a long process until they get their vision. They might still need contact lenses or glasses. That they need to attend for review. If they get hit in the eye, they could lose the eye. Unfortunately, some people seem to be a bit trauma prone. And if they're going to play contact sports, then the graft's not on. Yeah.
Thank you very much, Stephanie. And I'd really like to thank once again on behalf of the organization and on behalf of the Apots particularly for sharing a very important keynote. With that, we'd like to thank each and every participant and all the discussion, all the panelists for this thing. But just before we conclude, I would like to thank by presenting a couple of slides based on the today's learning point, at least to what I learned. I picked up, just prepared it just now while listening to all of you. Just to say that the key points from this today's meeting related to ophthalmic trauma, I just put it down and it's not in a particular sequence as it should be. But I just wanted to highlight based on all the 4 talks and including the keynote. The trauma is, we do know that from Stephanie's talk that it's a significant cause of vision loss as shown in the papers done by her and in the research she has done. As Dr. Ganga and Dr. Fazat pointed out in their discussion about the orbital trauma case, the first time is the best time to repair and you need to get in the best at that time. And same thing, Dr. Ganga also pointed out about the multidisciplinary team approach, particularly when managing some of the complex trauma cases. Again, the sequence has also been highlighted in Vivek's case and also been highlighted in the last case of the day was the life comes first, then the globe, and the globe was managed by Dr. Vivek, and then oculoplastic surgeon is taking care. And probably that's the place where husband takes over the wives before, right, Vivek, in that cases. So you've done the globe first, and then the oculoplasty will be managed by the rest of the team. Then save the eyes with no light perception. And even if ocular trauma score is less than 1%, probably go for the repair of the globe and do not give them the trauma of removing the eye at the first sitting, and does not justify that. And that was again learned in the case 3 and case 4, case 3 particularly. Ensure proper protection of the surgical team, but don't change the management in COVID-19 positive patient. This is from the case 2 from Indonesia. Dr. Eva's very good presentation. And she really put up a very important question, particularly in this context of last 2 years, what's been happening. And we don't know for how long this will continue to happen. Suspect globe rupture, even if it's blunt trauma, again from Vivek's case. Use of AC maintainer. Traumatic cataract, very nicely illustrated by the case number 1 by a dear friend from Bangladesh. So managing cases with small pupil was very nicely done. And once again, the learning tip here was get your best surgeon on the board and do not wait for it to be done at the second sitting. Further research is needed, and something which I always like to kind of call upon the people to do the trauma research work, I guess, and prevention is the key, and that's probably the last take-home message. So these are some of the key take-home messages from today's thing. I'm sure I would have missed out certain points, but these are the only points which probably I could make in this very engaging session. Thank you. And Dr. Ganga and Dr. Natarajan, anything to conclude? Just.
Now, I'll let Dr. Natarajan, the president of Asia Pacific Ophthalmic Trauma Society, make the concluding remarks. If not, thank you very much again. I'd like to thank the organizers, Dr. Rajiv, Dr. Girija from Kerala State Ophthalmic Society, giving us opportunity, and hope that each one of these webinars is going to continue to change all of our practice. I learned a lot personally, and I'd like to thank both the presenters and the discussers. Thank you again, all again.
Thank you, everyone.
Thank you. Thank you.